Hi everyone, this is Neel Raithatha, consultant audiologist and director of Clearwax. I'd like to start off by wishing you all a happy new year, and I hope you all had a wonderful Christmas also if you were celebrating. So this is my first upload using the endoscope of 2025, and it's of a patient who I saw a week or so ago, and they attended with this severe impaction in their left ear. I did initially start with the wax scope, but I decided to revert to the endoscope, primarily because this patient, I suspect, has possibly a grade 2 keratosis obturans. You can see the white peripheral matrix, which is typical of a keratosis obturans. And the other main symptom this patient had was severe earache, otalgia, which is also another hallmark symptom of keratosis obturans. In addition, they had some granulation tissue, which you're going to see appearing just there at the bottom of your screen. And there was also some bony remodeling of their ear canal, which is again typical of a keratosis obturans. And when we say bony remodeling, we mean a global widening of the ear canal. Now, the main, for me, diagnostic or clinical symptom of keratosis obturans is the feel of it when you're in the ear. And I could just tell this just had this rubbery ball consistency, which is typical, again, of a keratosis obturans. So keratosis obturans is a buildup of desquamous skin cells. So when we say desquamous, we mean shed skin cells. So the ear canal, as you know, is lined with skin, and this skin, it starts to migrate from the deepest region of the ear canal to the entrance. And as it does, when it approaches the outer half, the individual skin cells that are normally interlocked begin to detach themselves from one another, and then they flake away from the surface of the ear canal, and aided by your jaw movements, these skin flakes then exit the ear. So the ear has its own natural shedding mechanism of the dead skin. So with keratosis obturans, there's normally an abnormal migration of the skin. So instead of the skin migrating sideways from the deepest regions of the ear canal to the entrance, it can instead shed inwards, so towards the midline, to the middle of the ear canal. In addition, with a keratosis obturans, you typically find that these individual skin cells tend to stay interlocked, so they don't separate from one another. And overall, that gives you this lamellar structure. So it's almost like an onion. You've got these layers upon layers, and this plug of dead skin then gets larger and larger. And I always compare it to a rubber ball because it's got this elasticity to it. So this is a prime example. I'm using the ear pick to separate the back of this plug from the canal wall, and it just has this tendency of bouncing back. So it has a lot of kinetic energy, and that's because the skin is, as mentioned, it's interlocked, all the individual skin cells, and then it coils over itself. So it has this springy texture. So I'm just using the forceps. I've used the ear hook just to try to separate the back part of the plug. Now, the video is a bit unsteady, and that's in part due to the patient wasn't able to stay very still, and also they were clenching their jaw quite a lot. The patient wasn't able to stop. It was just one of those reflex actions. So we just had to accommodate for all that, which can be difficult because when the head's not steady. And you may tell by the orientation of the view, this patient's head was leaning forwards. So normally what you're seeing on screen at 9 o'clock will present itself around 12 o'clock. But because this patient's head was leaning forwards, we have this skewed view. So I'm just using the forceps again, and the suction wasn't really beneficial at this stage. It does assist a bit later on in the video. And here I've decided just to use some hydrogen peroxide drops. So that's that effervescence you're seeing. So the hydrogen peroxide, as it enters the ear canal, It reacts with perioxidase, which is a catalase enzyme, which is secreted by the ceremonous gland. So the ceremonous glands secrete oily, lipid and protein-rich sweat. And when hydrogen peroxide reacts with perioxidase, it converts into water and O2, oxygen. And when the liquid converts into the gas, you get this effervescence, and it's believed that this mechanical bubbling helps to break up the wax plug, in this case a skin plug. In addition, the water is absorbed by the individual skin cells. So the individual skin cells, the proper name is corneocytes, and it causes these corneocytes to overhydrate, swell and burst at the membrane. So it just helps to break up this plug. With keratosis obturans, olive oil isn't really helpful. It just hits the surface and kind of drains back out. It doesn't really penetrate. And here we want to break up this plug a little bit. It doesn't dissolve. Hydrogen peroxide doesn't dissolve, but it does help to break up. Now, in the UK, hydrogen peroxide has it's not readily available. But I work with a pharmaceutical company who manufacture a whole range of ear care products. So the olive oil that I use, for example, the Clear range, they're manufactured by a company called Pharma, and they've recently introduced hydrogen peroxide drops. Normally in the UK, you use hydrogen peroxide drops off-label for the ear, but instead of hydrogen peroxide, carbamide peroxide is used quite often, and carbamide peroxide contains hydrogen peroxide and urea in equal amounts, and it also contains glycerol. And the urea tends to break up the keratin, which is within the skin cells. Keratin is a protein not only found in skin cells, but it's found on your hair strands, your fingernails, for example. But the negative of urea, it makes the wax or the skin extremely mushy, and it can make it really, really difficult to remove. So if there's a choice between carbamide peroxide and hydrogen peroxide, I would use hydrogen peroxide. And at the moment, I'm just evaluating the difference between using sodium bicarbonate drops and hydrogen peroxide drops, because normally I would recommend sodium bicarbonate drops for keratosis obturans. But I've used hydrogen peroxide on a couple of occasions now, and it's worked pretty well. So it's kind of broken down this skin plug, and it's going to help me now suction it out. Now, I also performed the procedure in this patient's right ear. They just had a really impacted, it was a skin plug actually, but I wasn't call it keratosis obturans. It didn't cause any global widening, there was no pain. But in both ears, they have got a fungal infection. You'll see the fungal spores a bit later. It was much more present in their right side. So you can see this white peripheral matrix, which is again a hallmark of keratosis obturans. We're just trying to detach that which we have. I'm going to slowly bring it forwards. There's just a hair strand there in the way. There's a bit of an opening posteriorly. I'm just trying to separate the plug from the roof of the ear canal, so I'm just dragging it downwards. But it's here at the bottom. This is where you can see the white layer, which is the peripheral matrix. That's the most recent layer of skin that's attached itself to the keratosis obturans. It's a really, really thick layer, and this is really compressing against the canal wall, and that's why there's some granulation tissue formed. Now, normally when you have granulation tissue with the keratosis obturans, you classify that as a grade 3, but the widening, so it's probably a grade 2 stroke grade 3. You can see some granulation tissue on the left-hand side, the anterior canal wall as well. But I would normally expect more of a widening of the ear canal. And this widening of the ear canal can happen for two reasons. It could be the pure pressure caused by this plug just widening the ear canal. But what normally happens with keratosis obturans, underneath the skin that lines the bone, there's a layer called periosteum, and that supplies all the blood and nutrients to the bone. And the plug of keratosis obtrans, it compresses against the skin, which it then aggravates this periosteum, which then gets inflamed, and the inflammation then causes specialized bone cells that sit on the surface of the bone called osteoclasts to activate. And what osteoclasts do, they break down the bone into its kind of minerals and tissues, and it redistributes these minerals and tissues to other parts of the body where new bone is being formed via the bloodstream. So the bone in our body is continuously recycling itself. The outermost layer is getting broken down, and then it's getting replaced by new bone. And the reason for that is to help to keep the integrity of the bone. And there could always be bacteria on the surface of the bone, which can then weaken and denature the bone. So by the bone recycling itself and shedding its outermost layer, it just keeps the integrity of the bone. So we're about 10 minutes in, and visually it looks like we haven't done much. We have removed quite a lot already, but it's just bringing back. So I've just gone back in now with the ear pick. I'm really just trying to lift this off the back of the ear canal. And this is why I developed the ear pick. The ear pick was primarily for keratosis obtrans. I'm able to glide in a lot better. And I think I'm going to also, so you can see there's an opening now. I think I'm going to glide now, possibly, the angled right ear hook. And because it's tapered, it's got a narrow tip, I'm able to glide in again into the narrow space. I'm now rotating it. I'm trying to bring this forwards, and it hasn't come away, but I have separated it from the back part of the ear canal. I think I'm just using the ear hook again. I'm just going to turn this, as you can see, and trying to drag it forwards, but it's not, well, it's separated a little piece there, which I'm going to suction away, I think. There we are. But I have now almost chiseled this, broken it down, I've dissected it, so you're going to see little pieces coming away. For example, this piece there. I think in a moment I'm going to get a larger piece out. And it's quite typical of a keratosis obtrans. It's not a quick procedure. I always compare it to the game Jenga. It's when you remove one piece and it all then starts to crumble away, but to remove that one piece, it does take a while. So this plug, it's going to detach itself from the outside silvery matrix. So I'll have to go back in a bit later and remove that white layer, because that's going to remain in the ear canal, but this plug is now coming away. Just giving it a little wriggle. It's just a hair at the entrance that's got slightly oily, so it's just blurring the view slightly. You can see those hairs there. And eureka. So now that I've removed this plug, it's going to make the rest of the procedure a lot easier. So there are some of the fungal spores. But can't still fully see the eardrum now. I try and remove as much of the fungal spores as possible, but this patient's ear canal is quite angry. You can see how it's red in this region, so it was, I had to stop because it's just getting slightly uncomfortable for the patient. So they're going to use some antifungal drops, which should just finish off the job. So I'm just lifting this from the floor. It's really still strongly attached. So I'm just giving it this rocking motion. And the eardrum is now starting to reveal itself. You can see that in the distance. And I'm just going to mop up around the edge slightly. And the remodeling is just occurring beyond where the suction tip is. You can see where the ear canal is a bit more red. It's just a bit wider than the ear canal in front of it. So it's safe to say this patient experienced significant relief of their symptoms. There's a bit of granulation tissue just at the roof there as well. So I'm just trying to glide the suction tip across the surface of the canal wall with minimum friction, so it's not uncomfortable for the patient. And trying to separate this layer of skin. So it's quite angry, it's quite tender in there. So yeah, in an ideal world, I like to remove all that, but sometimes it's not always possible because you've got to take into account patient comfort, which is, for me, the most important thing when you're performing earwax removal, is to ensure the patient's always comfortable, or as comfortable as possible. I think the patient just found it slightly uncomfortable in this region. This is where it's quite tender. So it's very likely they've got Aspergillus niger, which is a common fungi found in the ear. Normally, the fungi that leads to otomycosis, which is a fungal ear infection, they normally reside in the ear without causing the ear any harm. So it forms part of the natural skin flora of the ears, these fungi with alongside some bacteria, so they're kind of healthy in that respect, but sometimes you can get an overgrowth. Having this skin plug in there is not going to obviously help because it can cause some humidity, some warmth, darkness in the ear, which is the conditions fungi really thrive upon. So it's just been an overgrowth, which then leads to immune reaction, and you can get a bit of inflammation as a result of that. You can see it's quite sore there at 9 o'clock on screen, so I think we just left the procedure at that. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.